Hello, my name is Mary Idowu, and I'm a Deputy Director in NHS England and Improvement. I'm going to tell you a few things that we've been doing this year and some things that we have planned coming up. So when we think of the NHS, we think of it as one organisation, when in fact it comprises of around 8,000. The organisation I work for, NHS England and Improvement, we're responsible for the budget, planning, delivery and day-to-day operations of healthcare under the Health and Social Care Act of 2012. Now, many of the organisations we work very closely with include integrated care systems, where we have 14 of them, or ICSs, 44 sustainability and transformation partnerships, around 7,000 GP practices, as well as mental health and community providers and ambulance trusts. Now, the work that I've been doing has very much evolved during COVID, and it really falls under four main pillars. Clinical insights, which underpins all the work that we do, and quite rightly so. Behavioural insights, process engineering, and knowledge transfer and management. And using any or all of those pillars, we expect to see a behaviour change. I'm just going to tell you a little bit about each of those. So thinking about behavioural insights, how can you use the best evidence to tailor and synthesise your messages to ensure that they're landing and that they're clear and they're actually encouraging the behaviour change that you're wanting to see, whether this is in guidance and policy, for the public or indeed healthcare professionals. Now, we've done a variety of work that's included or used behavioural insights. Some of you may be familiar with these posters. If you go from left to right, these were some of the early posters that were produced during COVID to reduce patients attending either a hospital or a GP practice when they had symptoms, all the way through to staying at home to ensure that you reduce the opportunity of transmission. At the top, you can see analysis that had taken place where we've worked with BIT, or the Behavioural Insights team, also known as the Nudge Unit, to really test some of those prototype posters to see, did they really resonate with the public, and did it indeed encourage that behaviour change that we wanted to see? And in these cases, it was around washing your hands. So which of those posters really resonated with the public to make them want to wash their hands more frequently? And that then influenced which posters were indeed published. As I said, we've done a variety of work using behavioural insights. It includes the Think 111 first. So rather than patients going straight to A&E, thinking to dial 111 before that they attend, as well as how you can reduce unintended consequences as a result of telling patients to stay at home. Now, thinking about process engineering, I'm going to use a tube map as a really simple example to try and explain this. So if I told 10 people to go from stop A to B, the likelihood is they'd all take a very different route. Now, it doesn't mean to say that they all wouldn't end up at the same journey, but there's no guarantee that they would all take the optimum route, which is the best route, the fastest route, the least changes, etc. So by trying to put an algorithm or a process in place, you'd reduce the ambiguity of the choice making, and therefore the inconsistent approach to delivery, and ultimately the unwarranted variation. When you think of algorithm decision making as a whole, many studies have been done that really demonstrate the benefits of algorithms. As a minimum, an algorithm or a process will have no difference on your outcome. But as you can see, 60% of algorithms have led significantly better decision making. So therefore, it really does support the case to see where you can put a process in place to reduce that unwarranted variation. And an example of this is with using radiologists. even 20% of the time, they will disagree with themselves over the same image without using an algorithm. So thinking about how we've used algorithms and process engineering during COVID, this is a piece of work that we developed with Warwick Business School to demonstrate that how decision making can be impacted during times of crisis. So when you're in crisis, for example, you're sleep deprived, you're stressed, you're under pressure to make a decision quickly, you can see very easily with the numbers, as soon as at point 3 where fatigue sets in, if you don't put a process in place, your position will deteriorate over time. Whereas if you add a process in place, this can support you working in a completely different way and enhance your decision making. So work that we have done has been with a variety of teams, leadership teams, etc., to try and help them with their decision making and think about what we call marginal gains. So it's much harder to improve one thing 100% of the time rather than 100 things 1%. Now, thinking about knowledge transfer and knowledge management, this is an area I'm really interested in. Whilst we deal with healthcare, it's not saying that any other industry can't influence and help us in how we operate. We developed some very close working relationships with ActionAid prior to COVID. They're an organisation many of you all know, work in crisis majority of the time. They support countries and governments around the world where sometimes they don't even have a hospital building. There may be floods, earthquakes, etc. So they're very used to working in what we called our COVID times at the beginning, which was quite new to us. We brought in ActionAid, the Disaster Emergency Committee, and Save the Children to help us with our working, how we could enhance what we do, using some of the knowledge and experience that they have from their industry. So despite being the humanitarian industry, there was lots that we could learn around how they operate. It's not limited to the humanitarian sector. We work with lots of industries, whether it be transport and rail, retail, etc., to help us in how we operate. So how can we synthesize that experience from other industries, both nationally and internationally, to enhance what we do? So just thinking about what's next. As you're well aware, we're in the midst of our wave 2. So we've been in wave 1, we've worked through that. We had a brief respite, and as we know, in the words of Game of Thrones, winter is coming. So not only do we have the usual system pressures around winter, we also have the added pressure of COVID at the moment. So how do we continue supporting the messaging to the public around wave 2, ensuring that patients are coming in for their appointments where required, so we don't make those unintended consequences worse. We reduce that health inequalities, etc. Recovery and restoration. Some services were turned off during COVID, so all resources could really be focused on mitigating what was happening with the COVID situation and making sure patients were treated in a timely fashion. So again, some of our work is going to be focused around how we can make sure those services are turned back on and we go back to not business as usual, but what some people are calling our new normal. Surge. We're in the midst of a surge at the moment, being that it's wave 2. But as with most industries, we have our peaks and troughs within the NHS, and winter is one of the ones we're very familiar with. So working with our partners to think about how, once we are moving through the COVID situation, we are managing our resources and surge in a timely fashion, but equally how we're supporting our workforce and patients are being seen in a timely fashion. Equality, diversity and inclusion. COVID has really emphasised the disparities in some areas, some of it ethnically, so the way how Black, Asian and ethnic communities have been affected by COVID, both the public and healthcare professionals, but also thinking wider than that, patients with learning disabilities, mental health. So some of those areas that we knew that we were challenged with prior to COVID, how can we ensure that both our workforces and the public are supported and we are not making those health inequalities worse? Well-being. As you can imagine, healthcare professionals have been doing a sterling job that have been working incredibly hard during COVID. So well-being is a real priority for us. So how can we support and look after our colleagues, knowing that some haven't had a break, some are still working at breakneck pace. And as I've already mentioned, using process engineering and behavioural insights to encourage the work and enhance the work that we're doing, knowing that there's value. So as I described at the beginning of the talk, we work in a massive system across the country in the NHS. And so the amount of decisions that are made at various levels, there are plenty of opportunities to see how we can enhance our decision making and how we can enhance the work that we produce using behavioural insights. And as you can see from the pictures, how we can go from this almost period of chaos to what some people probably haven't seen for a very long time, almost that serene holiday feel. Thank you so much.